Hi everybody, welcome back to this channel, and this is the third video of this series where we are discussing about the various cardiovascular pathologies from the book called as Robbins and Cotran. So this is the third video, and in today's video we shall be discussing a very important topic but a very short topic, just like the previous one, that is infective endocarditis. Now this turns out to be one of the most important and most asked questions both in our NEET PG as well as our professional examinations. So let us get into this video. So let us first just understand the basics. As the name suggests, it's infective and it's endocarditis. So infective basically and should deal with something related to an infection. So there must be some organism causing an infection, and endocarditis, as the name suggests, must be inflammation associated with the endocardium. So let us just get into the details. What are the things that we need to know in this case? So once we talk about infective endocarditis, it is a microbial infection of the heart valves and the mural endocardium that leads to the formation of vegetations composed of thrombotic debris and organisms often associated with the destruction of the underlying cardiac tissues. The aorta, aneurysms and other blood vessels and the prosthetic devices can also become infected. Although fungi and other classes of microorganisms can be responsible, but most infections are bacterial. Bacterial endocarditis, thus the name suggests. Now, prompt diagnosis, identification of the offending agent and the effective treatment of the infective endocarditis is important in limiting the morbidity and mortality. Any disease of the heart, when any organism actually affects the heart, it becomes very difficult for a surgeon or for a physician to actually get into its pathology and cure it. So if it becomes very evident that what is the causative organism of the particular disease, it becomes very much easier for the physician to diagnose the disease and treat the disease, because it's a organ which is situated deep inside the body. So getting that organ exposed and treating it is very difficult. So we need to diagnose the organ and the causative organism very properly. Traditionally, infective endocarditis has been classified on clinical grounds into acute and subacute forms based on the severity and the tempo, that is reflective microbial virulence, and whether there is underlying valvular pathology. Thus, acute infective endocarditis is typically caused by the infection of a previously normal heart valve by a highly virulent organism, example Staphylococcus aureus, that rapidly produces destructive lesions. These infections may be difficult to cure with antibiotics alone and often require surgery. Despite appropriate treatment, there can be substantial morbidity and even mortality. In contrast, subacute infective endocarditis is characterized by organisms with lower virulence, example viridans streptococci, that cause insidious infections of the deformed valves with overall less destruction. In such cases, the disease may pursue a protracted course of weeks to months, and cures can often be achieved with antibiotics alone. Of note, a clear delineation between the acute and subacute endocarditis does not always exist. Many cases fall somewhere along the spectrum between the two forms. So it is very difficult for us to distinguish between an acute and a subacute endocarditis, because the clinical features are almost the same. There might be very minute differences between these two. So most of the time, the clinical features fall within a spectrum between the acute and the subacute endocarditis. Now, let us just summarize what we learned. If we talk about the risk factors that are promoting this thing called as the endocarditis. Number one is damage to the endothelial lining, and it might be due to some rheumatic heart disease, or maybe a congenital heart disease, or maybe some artificial valves and prosthetics that might be present in the heart. There is presence of prolonged bacterial presence, maybe in case of septicemia, or maybe in case of immunosuppressed individuals, that is in case of diabetes mellitus or some people on steroids. Now let us just talk about the pathogenesis. Although highly virulent organisms can infect previously normal valves, a variety of cardiac abnormalities increase the risk of developing infective endocarditis. Rheumatic heart disease with valvular scarring has historically been the major antecedent disorder. As rheumatic heart disease becomes less common, it has been supplanted by the mitral valve prolapse, degenerative calcific valvular stenosis, or bicuspid aortic valve, whether calcified or not, artificial valves, and congenital defects. Endocarditis of the native but previously damaged or otherwise abnormal valves is caused most commonly by the Streptococcus viridans, a normal component of the oral cavity flora. In contrast, more virulent Streptococcus aureus organisms commonly found on the skin can infect either the healthy or deformed valves and are responsible for 20% to the 30% of the cases overall. Staph aureus is the major offender in infective endocarditis among the intravenous drug abusers. Other bacterials, which include things like enterococci and the so-called Hackett group, which includes Haemophilus, Actinobacillus, Cardiobacterium, Echinella, and Kingella, all the commensals in oral cavity. More rarely, gram-negative bacilli and fungi can also be involved. Prosthetic valve endocarditis occurring in 1 to 2 months after the surgical implantation is typically caused by the skin flora, Staph aureus and Staph epidermidis. Prosthetic valve infections 1 year or more after the surgery tend to be Streptococci and Staph aureus. In about 10% of all the cases of endocarditis, no organism can be isolated from the blood. Culture negative endocarditis. Reasons include prior antibiotic therapy, difficulties in isolating the offending agent, or because deeply embedded organisms within the enlarging vegetations are not released into the blood. Foremost among the factors predisposing to endocarditis are those that cause microorganisms seeding into the blood stream, like bacteremia or fungemia. The source may be an obvious infection elsewhere, maybe a dental or a surgical procedure, a contaminated needle shared by the intravenous drug users, or seemingly trivial breaks in the epithelial barriers of the gut, oral cavity, or the skin. In patients with valve abnormalities or with known bacteremia, infective endocarditis risk can be lowered by antibiotic profile access, just like any other disease. Now let us summarize what we learned. In case of acute infective endocarditis, what happens? The causative organism is mostly Staph aureus or maybe Streptococcus. In case of nosocomial infections, the causative organism is Staph aureus solely, and it might cause damage to the previously healthy valves. But in case of subacute infective endocarditis, what happens is the causative organism is mostly Streptococcus viridans, and it affects the previously damaged valve due to some infections by less virulent organisms such as Streptococcus viridans. And it is more common in case of intravenous drug abusers, where the tricuspid valve is affected by the organisms such as Staph aureus. In case of valve surgery, If it occurs less than 2 months, within a time period of less than 2 months, it is mostly due to staph epidermidis. And if it occurs more than 2 months, after 2 months of the surgery, then it is mostly caused due to streptococcus. Now, the causative organisms also include a certain group of bacteria called as the Hackett group of bacteria, which basically includes H for Haemophilus, A for Actinobacter, C for Cardiobacterium, E for Echinella, and K for Kingella species. Now let us get into the clinical features of this disease called as infective endocarditis. The acute endocarditis has a stormy onset with rapid onset of fever, chills, weakness, and lassitude. Although fever is the most consistent sign of infective endocarditis, it can be slight or absent, particularly in case of older adults. And the only manifestations may be non-specific fatigue, weight loss, and a flu-like syndrome. Murmurs are present in the majority of the patients with left-sided infective endocarditis, either from a new valvular defect or from a pre-existing abnormality. The modified Duke criteria facilitate the diagnosis of individuals with suspected infected endocarditis by taking into account the predisposing factors, physical findings, blood culture results, echocardiographic findings, and the laboratory informations. The complications of infective endocarditis generally begin within the first few weeks of onset and can include glomerular antigen antibody complex deposition, causing glomerulonephritis as well. Sepsis, arrhythmias, and systemic embolization bode particularly ill for the patient. If left untreated, infective endocarditis generally is fatal. However, with appropriate long-term antibiotic therapy and or valve replacement, mortality is reduced. For infections involving the low virulence organisms, example viridans, the cure rate is 98%, and for enterococci and staph aureus infections, cure rates range from 60 to 90%. However, with infections due to gram-negative bacilli or fungi, 1/2 of the patients ultimately succumb. The cure rate for endocarditis arising on prosthetic valves is uniformly worse, and valve replacement is commonly required. Earlier, the diagnosis and effective treatment has nearly eliminated some previously common clinical manifestations of long-standing infective endocarditis, for example, microthromboemboli or erythematous or hemorrhagic non-tender lesions on the palms or soles. Those are known as Janvey lesions, subcutaneous nodules in the pulp of the disease known as Osler nodes, and retinal hemorrhages in the eyes known as Roth spots. So let us just summarize whatever we learned. First of all, it's done, the clinical features and the clinical diagnosis is done on the basis of Duke's criteria. Now, what is Duke's criteria? What are the things that are taken into account while using the Duke's criteria? The bacterial culture is taken into account, and the culture is collected about 1 hour apart, and these are then used for diagnosis. Moreover, echocardiography is also done for a proper diagnosis. That is what basically Duke's criteria includes. Now let us talk about the clinical features that we just saw in the texts from the Robbins. Fever turns out to be the most consistent clinical feature. We have talked about Roth spots. Now what are Roth spots? These are retinal hemorrhages. We have talked about Osler nodes. These are painful lesions in the pulp of the digits. We have also talked about Janvey lesions. These are painless lesions present in the palms, and there are characteristic changing murmurs, which is a characteristic finding in case of infective endocarditis. Now let us talk about the non-bacterial thrombotic endocarditis. NBTE is characterized by the deposition of small, about 1 to 5 mm sterile thrombi on the leaflets of the cardiac valves. Histologically, these are bland thrombi loosely attached to the underlying valves. The vegetations are non-destructive and they do not elicit any inflammatory reactions. Although the local effect of the vegetations is usually trivial, they can be the source of the systemic emboli that produce significant infarcts in the brain, the heart, or somewhere else. NBTE is most often encountered in the debilitated patients such as those with cancer or sepsis. Hence, the previous terms medantic endocarditis, which basically means a root word for marasmus relating to malnutrition. Valvular damage is not a prerequisite for NBTE. Indeed, the condition usually occurs on the previously normal valves. Rather, hypercoagulable states are the usual precursor to the NBTE. Such conditions include chronic disseminated intravascular coagulation, hyperestrogenic states, and those associated with the underlying malignancy, particularly mucinous adenocarcinomas. The latter association is likely related to the procoagulant effects of tumor-derived mucin or tissue factor that also cause migratory thrombophlebitis, which is basically Trosso's syndrome. Endocardial trauma, as from an indwelling catheter, is another well-recognized predisposing conditions. There is another thing which is basically the endocarditis related to systemic lupus erythematosus, which is also known as Liebman-Sachs disease. These are small sterile vegetations in the setting of the systemic lupus erythematosus, as termed as Liebman-Sachs endocarditis. The lesions develop as a consequence of immune complex deposition with activation of complement and recruitment of the Fc receptor bearing cells. Histologically, there is an intense valvulitis and fibrinoid necrosis of the valve substance. The vegetations can occur anywhere on the valve surface, on the chordae, or even on the atrial or ventricular endocardium. Persistent injury can eventually result in valvular scarring and leaflet fusion, analogous to that seen in the rheumatic heart disease. Similar lesions can occur in the anti-phospholipid antibody syndrome as well. So let us summarize what we just talked about in case of NBTE and Liebman-Sachs syndrome. In case of NBTE, the vegetations are small and sterile. These are present along the line of the course of the valves. These are high risk of embolization, associated with high risk of embolizations, and these are mostly seen associated with some genetic abnormalities associated to the AML3 gene, or in cases of pancreatic cancer as well. Now let's talk about the LSE, Liebman-Sachs endocarditis in systemic lupus erythematosus. In this case, the lower surface of the valves is more affected. These are usually small and are usually sterile as well. But in here, no embolization is seen as is seen in case of NBTE. So with this, we come to an end of the discussion of this topic called as infective endocarditis. So this is the last but one video of this series of videos related to the cardiovascular system. In the next video, we'll be talking about the vascular diseases and vasculitis, various kinds of vasculitis. With that, we'll come to an end of the discussion of the cardiovascular system. Here we stop today in this video. If you like the video, hit the like button, subscribe to the channel, and share this video with whoever might find it helpful as well. Thank you. All the best.